Do you want to call for
Bismillah ar-Rahman ar-Rahim. Welcome, ladies and gentlemen. We would like to start our 8th session of the scientific program, and I would like to request my co-chairman, Dr. Salman Qureshi, to present the first speaker.
Assalamu alaikum, Jazakumullah bil khair. I hope everybody is awake, and I know it's late, and but interestingly, we have an excellent speaker at this session. We'll start by Professor Timothy Pruett, who is a professor of medicine, as well. He's head of Division of Transplantation in the University of Minnesota. He's also the Professor of Internal Medicine, as I mentioned, as Strickler Family Professor of Transplantation. Please welcome me, Dr. Timothy, and we're looking forward to hear from him.
Thank you very much. Congratulations to those of you who are making it through to the end. I was assigned today, let's see if we can get this slide up. I was assigned to talk about disease transmission through organ transplantation. For those of you who heard the talk about risk factors, there's not too much overlap with this, but there will be some. It happens. We had a case in the US back in 2007. You can see 4 people got HIV. But it was only the first case in 22 years. And so it brought to bear on us as a system, how do we figure out what we need to tell people? What do we do? Is this too much? Is it too little? And the rest. It has stimulated a tremendous amount of interest in the United States. In both the Middle East, Europe, North and South America, organs are shared across some national boundaries. You heard about that yesterday with the various folks who talked about moving organs through the GCC. In Europe, clearly through Eurotransplant, organs are moved across national boundaries. In North America, we do a little bit of sharing, not a whole lot. We send a few lungs to Canada and South America. The WHO has gotten involved with this. They're very intrigued by this, and they recently passed an agenda item, 6322, on human organ and tissue transplantation. That has spun out two agenda items. One is the Notify project, and the other is the SONG project. Notify is basically an international registry of adverse events, which will be available to categorize and help people understand adverse events through transplantation. And SONG is the request for an international standardized nomenclature in the use of an ISBT 128 as a notion. In the US, we've had a gap analysis of our system and said we have problems in biovigilance. There's been a request for information from HHS about the public-private interest in biovigilance and trying to set up a national system linking organ, tissue, blood, cells. And then there's been a variety of different other events which we can talk about later. Well, this is sort of what stems this stuff. One was the HIV transmission. Here's an instance which we had just recently within UNOS with a 4-year-old child who was admitted with seizures, discharged, came back and died. All the serologies were negative. The donor narrative which came with the request for placement was this was a donor who had the diagnosis of acute disseminated encephalomyelitis. Per a pediatric neurologist, this was not transmissible to potential recipients. He was wrong. This was not the encephalomyelitis of that. It was an meningoencephalitis caused by Balamuthia mandrillis. And organs were taken, heart was transplanted, that fellow was fine. The liver was transplanted, that person was fine. Kidneys were transplanted. Both of those individuals came back to the hospital with confusion, and both of them died from meningoencephalitis associated with the Balamuthia infection. So the point is, and this is going to be the discussion today, people die and some of them become organ donors. How do we know what's with them and how do we know what's not, and where does the responsibility lie? Where does our responsibility as the transplant community lie, and where do other people go? This was a slide I showed the other day just listing a whole bunch of things, looking at relative prevalence within the country, within our country, of routine infections. Not one of them up there will be Balamuthia, by the way. And here's our policy, which is how to find out what organs are, and none of those things which are up there is you can see the HIV, the Hep B, the Hep C, the anti-CMV, the EBV, the syphilis. None of those things will deal with what's in the newspaper. What's in the newspaper is the balamuthia. What's in the newspaper is in the hamster virus, the lymphocytic choriomeningitis, the arena type viruses. These are the things that we want to figure out. What's in the organ? How frequently does it get out? And what do we tell our patients to try to figure it out? This was the slide I showed the other day of the men crawling out of the organ. We find things that come with the organs that we don't expect. They come in and they take over the patient. They open the gates of the city, and all of our defenses are lost and the city is overrun. But a lot of things happen. When infections come with an organ, a number of things happen. One is sometimes we know they're there and we accept the risk, and that's just what we expect. And that's what we get a lot with CMV and hepatitis C. We know the virus is in some of these folks. We take it. We either have effective prophylaxis or the people already have the disease, and so be it. Some infections come and they cause almost no disease at all, and we never even realize that they're there. Some have latent infections in which the donor has something that could be problematic. Some of that is things like BK virus. There are some rare diseases, and I use the in rare only because they're not rare in some parts of the world, that are not readily tested. And these things are things such as Chagas disease, coccidioidomycosis, balamuthia, West Nile virus, rabies, lymphocytic choriomeningitis. And then there's some things that donors get while they're patients before they become donors. And those are the infections that come out of the ICU. And the question is, how do we figure out which one of those things we need to talk about, which organs do we turn down because of a risk, and which ones do we use? I use CMV because it's something that we've known all along, and it serves two functions. One is it talks about an infection which oftentimes doesn't cause obvious disease, and the other one is that it causes a disease that we can sometimes treat. Prophylaxis has really changed what we do. But the prophylaxis, chemoprophylaxis, is only part of the immune prophylaxis that goes through. So if a recipient has been CMV positive, the disease changes. This is one of the studies which was in the literature from years ago. We participated in the PV 16000 study, which looks at the prevalence of CMV in the blood in people receiving either ganciclovir or valganciclovir. And you can see on valganciclovir or ganciclovir prophylaxis during that first 3 months, there's an X number of people, 10%, 5%, who develop detectable CMV. And it goes out to almost 50% as you go out during the first year. But if you look at the number of people who are actually treated, who recognize with disease, you can see that it's a much lower number, suggesting that there are two things. One is that it does occur and it gets transmitted, shock. But two is that there are plenty of transmissions which would only have been determined because you did a routine culture, which otherwise would not have ended up being investigator-initiated treatment. And the crux of the issue goes on the bottom part of that thing, looking at the donor-recipient profile, talking about whether or not the recipient has immunity such that there can be an attenuation of the virus to the extent that when you get viremia with the virus that came with the organ, that in fact it causes minimal disease or no disease at all and only viral infection. So this is the other cause. This is this slide demonstrating what you get if you have Hep C and get a kidney transplant. Well, actually, it's 4 slides. The top slide up here, the green line, is the CMV or the HCV negative recipient who receives an HCV negative kidney in the U.S. And this is a 10-year attenuation study, and you can see the results are pretty good. These 2 lines right here are the Hep C positive recipients who receive either a Hep C positive organ, which is the top line, or a Hep C negative organ, which is the top line, or a Hep C positive organ, which is the bottom line, showing that the results were essentially identical between these 2 populations, such that we actually think that, quite truthfully, that it doesn't matter whether a Hep C positive person receives a C positive organ or not. But the bottom line is the immunologically naive Hep C negative recipient who receives a Hep C positive kidney, which has a distinctly worse outcome than does any of the other groups. So another example of the infection that you can get without getting disease is adenovirus. During the same PV 16,000 study which we did, Dr. Humar went back and he looked at the serum samples that we had looked for CMV and said, well, let's look at another virus. Let's do adenovirus. And he found that upwards of almost 10% of liver recipients and 5% of kidney and heart recipients who were on the Valgan study actually had an adenovirus, and essentially all of them were asymptomatic. So infections we know can get transmitted. Oftentimes, though, they're irrelevant. Adenovirus does cause plenty of disease, but how can we discriminate preemptively looking at the donor whether or not we will end up with an infection or a disease? So let me just go through. There's a spectrum of diseases. We'll reiterate it. Or a spectrum of transmissible infections that come through the organs. There's infections that do not produce disease. There are infections that have a minimal disease that is short-lived, sort of like CMV is typically. There are infections with serious, but they're very acute, limited diseases, and that's typically the bacteria. There are infections that produce chronic disease that require treatment, such as potentially HIV, Hep B. There are infections that can produce chronic disease that have minimal treatments, and that's some of the funny fungal diseases, although most of them are now treatable. And then there are infections that come up very rapidly or not so rapidly and kill people altogether. Huge spectrum, so that when people talk about this entity, you have to sort of say, what are you talking about? Are you talking about infection or disease? You're talking about the disease that kills people, or are you talking about the disease which is just an inconvenience? Well, in the U.S., we've had a system which has tried to look at this, which is in a systematic way. We've established the Disease Transmission Advisory Committee for the country. It started only about 5-6 years ago. We review all the reports, and now let me deal with that as an important issue. It reveals all the reports of potential disease transmissions, and then it informs the centers about the fact that there was something else seen at another center. It doesn't tell people how to treat things. It sort of serves as a warehouse for whether or not it is, in fact, by using peer review, it tries to make an ascertainment as to whether or not the infection actually came from the organ, or whether it's just the consequence of the fact that we did a big operation on a sick person and put them on immunosuppression, and they developed an infection that would have otherwise have been there. So we have a classification, expected or unexpected. This committee only deals in principle with the unexpected. And then we try to break things out into either proven, probable, possible, or in the group of people who receive treatment without any documented intervention, without any documented transmission, or unlikely. The Europeans have said no, that there's a group which has said no transmission. Here are the number of cases which have been reported. We're clearly in a learning reporting curve which is going through. We're currently going to do this year about 160 or so cases. It looks like we're starting to plateau the number as we go forward. It looks like we will be seeing somewhere between 150 and 200 reported potential events that come through unexpected transmissions in our country. In 2010, we had 8 malignancy reports, 12 non-malignancy events. These are actual, what we think are proven or likely transmissions. 8 of 11 deaths of tumors, 6 of 16 deaths with the infections. The summary of the events that has occurred over a longer period of time demonstrates there have been 342. We're almost now up to almost 500 cases that have been reported. The number of recipients with confirmed transmission has been 141, and there have been 34 attributable deaths to disease transmission through an organ since that time. It's heterogeneous across the country. Those are the OPOs which report. It's highly disparate. And the important number down here is at the bottom is that of the recipients that actually get something with them from an infection, about 10 to 15% of them will die from it as we currently as we currently receive it. The total number of people who end up with of donors is about 0.5% of all the donors that we have in our country have some proven form of transmission, unexpected transmission of disease, of infection, or tumor in the country. And so it's a real number, but it's not a huge number. I want to talk about a couple of things: bacterial infections, regional infections. The bacterial infections, we've had 404 cases reported, 61 involved, of the 404 cases reported, 61 have involved bacteria. 31 of the cases were conventional bacteria. The other 30 were AFB or syphilis. Of the 38 cases, 14 donors potentially transmitted infection to 25 recipients. And if you look at the pyogenic bacteria, which is the major problem that we see, you can see those are what happened. 9 of the people who got it died. Most of it was Pseudomonas. There's a number of grafts which blew out mycotic aneurysms, which we've had, which typically resulted in deaths. We've had several grafts that have had to be pulled because of bacterial transmissions. They've mostly been bacteria that you know cause problems: Pseudomonas, Serratia, Klebsiella, and E. coli. They have caused it, and it comes from the respiratory tract of the donor: blood, peritoneal fluid from a contamination from a gunshot, blood, respiratory, lung, pneumonia, and you can read down. So the summary is it's a significant mortality of people who finally get bacterial infections. 9 out of the 22 people died. Almost all the grafts were lost, and so that we need to be very careful. The bacterial contamination of the blood is very common in organ donors, and so that you can't overreact to it, otherwise you're going to dump a lot of organs out. But be very cautious of the gram-negative rods that come out in bacterial infections, and be very cautious of somebody who has diffuse contamination of the peritoneum and not just a localized abscess. The high-risk donor is defined by the CDC as interesting. We've had 51 of those, 51 reports of potential infections. You can see the numbers there. There is no increased risk that we can determine today of probability of disease transmission from the high-risk donor that the CDC defines for any type of things. And when you looked at the reports that came through, the bloodborne pathogens only represented about 1/4 of the infections that came through, and the other things which are recognized are bacteria, fungus, and parasite. The other thing which is an important component is the undiagnosed mental status encephalitis. That was the one that we had with the Balamuthia infection at the beginning. These have been the ones that have been the problem. We don't know the denominator of what this is in our country, but it is the population that turns out to turn up with the lymphocytic choriomeningitis and the arenaviruses. It's the rabies. It's the West Nile virus, it's coccidioidomycosis, it's histoplasmosis. It's a variety of the things which will end up, which sporadically kill an organ recipient. So be exceedingly cautious if you end up having a donor come from a hospital with a good neurologist and they can't figure out why that person died. There's a real risk that you will give something to a patient. Just had a case that got referred back to me from one of my friends. They couldn't place an organ in an 8-year-old. They got really irritated for this exact reason, but they went on and did a post after none of the organs got used. It was a Balamuthia infection of the brain, and it probably would have been transmitted to folks. Our problems which still have to be addressed, our testing keeps changing. HTLV 1 and 2 platform's not there. Hep C platform is changing. Nucleic acid testing is going to be a complete thing. The question is going to be, when is it a false positive? When are we going to lose more organs? The adequacy of the historian, which I talked about the other day, is there, and then new diseases that we can't test. I'm not going to talk about our lessons we learned, but what I want to end on is this, is the relative risk. There are clear-cut risks of disease transmission. However, in 2009, we had over 100,000 people on our wait list in the United States. We added 54,000 people then. We removed 21,800 folks because we transplanted them. We did 6,600 live donor transplants, but we took off 10,700 people because they either died on the list or they became too sick to transplant. During 2009, we had 13 deaths and 101 recipients who got disease transmission from the organs. In 2010, 14 deaths and 123. What this is, it's a relative risk. You can see the discard codes of what we do. The one little blue sliver up there at the top below the 14.8 is the infection risk. Everything else is a different component, at least for why we discard kidney organs. Biovigilance is going to have to be balanced. There has to be a positive and a negative side. Don't overreact on the side of prevention of disease transmission, because there are just too many people who need organs and good organs on the other side in order to make it work. Finding that right balance, however, is not only about the medical community. It's about the patients or the recipients who have to find this balance as well between their risk of dying without an organ versus their small but real risk of receiving an organ that will give them something that they don't desire. I'm sorry that I went 5 minutes over, but I tried to make up time. Thank you very much.
Thank you, Dr. Pruett, and it was elegant and nice presentation. Any question, please? One or two questions?
I have a question, please.
Please. Yes, ma'am.
Dr. Timothy, thank you for your nice presentation. I'm just interested in microbacteria infection in TB. It's not common in USA, but it's very common here. Yeah. I have seen in your slides 2 patients who who've been transplanted have recurred, or they have recurrence of the TB in them out of 10 recipients. The question is, do they get the recurrence because the donor is tuberculosis patient, or they get the recurrence because they have dormant focus of TB, and then it flare up because of the immunocompromised situation and the immunodepressant drugs?
We think that, first of all, we're not 100% sure, but we think that what you get is a small inoculum with the organ that, because of the immunosuppression, allows for proliferation and dissemination. So typically these folks end up with miliary TB, widespread TB, which is very difficult to diagnose. With the global travel and everything else, we do see a fair bit of, which really causes us a lot of fits, when lungs come out and somebody sees a big lymph node that they then send for a culture or for histopathology later. We will oftentimes, after the organs are transplanted, somebody will come back and say that there's an AFB inside the node. And then everybody has to scramble on what do you do with it. And almost all of the recipients of those will receive either standard prophylaxis or multiple drug resistant TB prophylaxis, depending on which part of the world the donor came from. It's a tough issue. We've not had a lot of disease transmission and infections, or disease transmission. We've had probably a large number of small inoculum transmissions, which fortunately were recognized, and recipients have all been placed on extended prophylaxis, which seems, at least to date, to have worked reasonably well.
Thank you.
Yes, Dr. Awad, please.
Push your button.
Thank you very much. I think I like your talk, and one thing it just crosses my mind: is it time to initiate something like this in Saudi Arabia? And especially that we have a different group of donors. Right. And do you think you'll have an international chapter in your DTA just to include other did you survey other literatures about infections transmitted through donors?
Yeah,
what we have seen is only the data in the United States. Right. But it's completely different in the rest of the world, and I'm sure the incidence of disease transmissions from donors is greater than the relative risk you mentioned in your slides. Right. And did you add anything for your surveillance of donors before you retrieve organs from them, especially in diseases that cannot be diagnosed biochemically or by blood test, and you need a tissue culture to make a diagnosis, in fungus in particular? Thank you.
Yeah, and thanks, Abdullah. That's a very good point. This literature is anecdotal only, and getting the denominator of the total incidence of disease transmissions that occur with the denominator of both donor characteristics and the like is difficult. I always used to think that Cryptococcus was only a disease that came in the recipient and not donor-derived. However, when we went back and started looking at the aggregate cryptococcal disease transmission, turns out that almost 10 to 15% of all cryptococcus which is infected happens within less than the first month, which looks like organ-derived. And we've had several cases where donors they've actually done fungal infection cultures or fungal cultures of the donor blood have had cryptococcemia during their ICU time, and they have transmitted cryptococcus. So I don't know what the incidence of cryptococcal transmission is, as an example. Your point exactly. And you're also dead right that different parts of the world have different diseases. Certainly Southeast Asia has a much higher incidence of parasitic diseases than we do. There's certainly more dust-borne diseases in this part of the world than we have in our part. Although in Southwest United States, where we have a large desert, and certainly Los Angeles, we do know that the regionalization, where we never see coccidioidomycosis anywhere else in the country, but it's pretty common out of the LA region. So that we don't have a denominator yet. So all you can say is that you really do need to know the local endemic diseases which live in your area, and so that if you have a fair bit of, say you're from the Caribbean and you have a fair bit of strongyloides, look for strongyloides. If you live in Central America, look for Chagas disease. If you live here, look for the dust-borne pathogens, as well as the ICU organisms. That's why I talked about the bacteria. We typically poo-poo the positive blood culture in our organ donors. And your donors here spend more time in the ICU than some of our donors in the West. So that I think it's probably a significant issue that needs to be at least looked at as a component part.
Thank you. So we'll close the session. Thank you, Dr.
Thank you.
Pruett. And next speaker, Dr. Ayman.
Yes, our next speaker is Dr. Ayman Karkar, a well-known figure in the nephrology scene in the Kingdom of Saudi Arabia. Dr. Karkar is a consultant nephrologist and director of Canoe Kidney Center. He is supervisor of renal centers and services, in addition to being director of the Mam Medical Complex in the Eastern Province of Kingdom of Saudi Arabia. Despite his busy schedule, he has managed to find time to publish about 64 papers in national and international journals. I'd like to welcome Dr. Karkar, who for the next 30 minutes will present to us a very important topic, namely cardiovascular complications in transplant patients, and I'm confident that Dr. Karkar will keep time.